Hello, everyone. And thank you so much, Dean Rutherford, for that very generous introduction. So I just want to thank you all for joining us today. We're here for a very exciting celebration. We are celebrating the 20th anniversary of the ARKids First program in Arkansas, and you'll hear a lot more about it during this next hour. But this month marks a very historic moment in Arkansas's history as we look back over the progress we've made in the healthcare system, and we're anticipating the future of healthcare not only in our state but also in our nation. Today we're celebrating some major gains that we've made in the healthcare system in this state because of the ARKids First program. Because of the ARKids First program, we get to say that over 95% of kids in the state of Arkansas have access to health care coverage. And that's definitely a clappable moment. We have achieved the lowest rates ever in the state of kids who are uninsured, so just under 5% of kids. And so I mentioned that this month marks that anniversary. So in 1997, the state of Arkansas essentially just changed the healthcare system as we knew it by making the decision to make some important investments in kids' health. In the midst of a budget crisis in Arkansas, then new Governor Mike Huckabee called a meeting of a task force actually to discuss cuts that we needed to make to the Medicaid program. However, that task force actually walked away with a pretty surprising recommendation that would again change the system in Arkansas. It would make us a national leader, and it would improve outcomes for kids throughout the state. So I invite you to listen closely before we hear from our panelists as we share the story of ARKids First in a special video presentation.
When I got ready to sign the bill, I thought, I'm going to sign it with one of those kids' crayons. So I reached over and I said, can I borrow this? And I took a crayon, and to my knowledge, it is the only time in the history of Arkansas that a piece of legislation was signed by a crayon.
Obviously, Arkansas has, I think, led the country in terms of reducing its rate of uninsured kids.
Well, you cannot help but be proud of going from near the bottom to near the top on something that's as important as helping children access health care.
Until that time, there had never been anything quite like this. So Arkansas, in creating ARKids First, really created a template for what later would become SCHIP, where a lot of people see SCHIP as sort of the Children's Health Initiative. You know, those of us in Arkansas could say, yeah, they got the idea from what we did.
But the fact that Arkansas, low-income southern state, stepped out and did this early, I think got people's attention, and I think showed people what could be done. We had a task force that had been created by the previous governor of about 35 members whose mission was to find ways to cut Medicaid spending.
I mean, what folks have kind of forgotten over the years, that what prompted this conversation initially was that there were proposed Medicaid budget cuts on the table.
Well, the meeting was an assemblage of people from really across the spectrum who were involved in advocacy for children, health care, Medicaid.
Amy Rossi at Arkansas Advocates called me the day before and said, well, instead of all this talk about cuts, why don't we ask him if he would consider expanding coverage to kids?
I knew some of my colleagues thought I had lost my mind.
And she made a very, I thought, logical and rational appeal for why aren't we doing something for the uninsured kids?
And this new governor, he didn't think about it very long. He said, that makes sense. That's a good idea. We need to do that. And that's the way it happened.
For her in that meeting in front of all those people to raise her hand and say, here's what we ought to be doing. Would you be willing and interested if there's a way to get this done? It took a lot of courage on her part.
So we just kind of went for broke that day, thinking, you know, if he wants the plan, we've got a plan.
It took nerve, but she's never been short of that, so.
It was the day's work. So, you know, maybe, I kind of don't think if you don't have some of that gutsiness in you, advocacy is not a place you need to be.
Once it got established, I don't ever recall but a handful of people who just didn't like it. Most people, even those who had been critical before, realized, my gosh, this works.
I think like a lot of things, ARKids First came to be because of a special combination between political will and social need. You know, so somebody like Amy Rossi was able to articulate that social need, but there was also political will to help kids.
The political will hadn't been there, and getting the political will all at the same time lined up was sort of magic.
I think the fact that I was a Republican in some ways gave it maybe a little bit of boost that it might not have had, because people weren't expecting a Republican to be advocating something that some would see as an expansion of Medicaid. I saw it as an alternative to the traditional form of Medicaid that would put a wider net around people that had nothing and people that were working. These were working people.
Leaders made the choice to come together and come up with a solution to improve the health of kids in our state. And it was not a political debate. It wasn't based on what party you were affiliated with. It was just about how can we do better for the kids in Arkansas. Just thinking about long-term the economic development of our state, we're investing in these kids early and ensuring that they can become healthy, productive adults. And I'd like to think that I'm a good example of the return on that important investment in kids in Arkansas.
There was a family over in Polk County, which is Mena area, and this man had been getting medicines for his kids at the farm supply store. And when they needed medication, he got medication that was intended for animals, antibiotics. And he was doing all he knew to do because he couldn't afford the medications at the pharmacy. And he was making do. Now, you know, that got to me. And I thought, my gosh. Here's a dad, and you know, he can't afford medicines for his kids, so he's going and trying to do the best he can by getting him an antibiotic that was intended for a puppy. I mean, ARKids changed that. And man, how can you not think that's a good idea?
So before we proceed, I also want to recognize not only two stars in our video, but stars to our state in the pivotal role they played. Amy Rossi is here with us today, as well as Ray Hanley. And Ray Hanley is here as well. Thank you all so much for your hard work. Wow, that's how I feel when I see that video. And as you may have noticed, in addition to this being very professionally important to me, it's obviously very personal for me as well that I get to be here today talking about the importance of the ARKids First program. So now I want to introduce you all to two of my friends who are also experts in the field of healthcare, and they're going to talk more about really where we've been in terms of the history of kids coverage, how we got there, and where are we headed, what's going on in the future of health coverage for kids and their families. So first, Elizabeth Wright Brack, please come on up. She is the Senior Program Director and Research Faculty at the Georgetown University's McCourt School of Public Policy Center for Children and Families, known as CCF. At CCF, she directs projects focused on young children's development, tracks federal legislation, and supports CCF work with other national partners. She's had more than 15 years of experience in public policy to support low-income children and families at the national level and in states. As director previously of health policy, my current position, at Arkansas ARKids for Children and Families, Elizabeth actually helped lead successful coalitions to expand access to ARKids First. In addition to Medicaid improvements, she helped achieve other victories for families at the state capitol in Arkansas, including tax relief for families living in poverty, and increased access to school-based health, substance abuse treatment, and after-school programs. She originally turned to her home state of Arkansas to work for the Department of Human Services and the Office of Policy and Planning, where she also worked on several cross-system initiatives, particularly reforming children's behavioral health. And at the national level, she worked with state leaders on after-school and early childhood programs with the National Governors Association Center for Best Practices and the Finance Project. She received her Master of Public Policy and Master of Social Work degrees at the University of Michigan and a Bachelor of Arts from Smith College. Please join me in welcoming Elizabeth. So I'm going to quickly introduce Dr. Nash as well. She's a medical director with Arkansas Blue Cross Blue Shield. In that capacity, she's worked with both the Medicaid expansion and Medicare populations in this state in Arkansas. She has extensive history in combined clinical practice, health policy, public health, and community advocacy work. Her past work includes working as an assistant professor in the Department of Health Policy and Management and the Division of General Internal Medicine at the University of Arkansas for Medical Sciences. She's also served as the medical director for Arkansas Minority Health Commission. Her primary interest is in clinical practice and how you can translate that research into programs and policies to improve the health of populations. Dr. Nash has taught both health policy and co-directs a service learning course on racial and ethnic health disparities at UAMS. Additionally, she has assisted in informing health policy decision makers through her research with Minority Health Commission, Department of Health, and several community-based programs. Dr. Nash received her medical degree from the University of Maryland at Baltimore School of Medicine and completed a residency at George Washington University in Washington, D.C. She was also a Commonwealth Fund and Harvard University Fellow in Minority Health Policy and received a master's degree in public health from the Harvard School of Public Health. Again, I told y'all they were experts. So please join me in welcoming Dr. Nash as well. Take it away.
Oh, thank you so much. It is so great to be home and to be part of this celebration with all of these giants in healthcare in Arkansas. So I'm just honored to be here, especially with two of my favorite organizations in Arkansas, Arkansas ARKids and the Clinton School. So Georgetown Center for Children and Families, where I am now, is based at the McCourt School of Public Policy, as Marquita mentioned. And we are a research and policy center with a mission to improve affordable, high-quality health coverage for children and their families. And we particularly focus on low-income families, so we spend a lot of time thinking about a lot of the complex policy issues with Medicaid, the Children's Health Insurance Program, and these are the federal funding sources for ARKids First in Arkansas, as well as most recently the Affordable Care Act. So that is sort of how we do our business. So let me see if I can, there we go, good. So Marquita mentioned that in Arkansas and nationally, we are at our lowest levels on record of uninsured kids, under 5%. And this data sort of reflect the most recent recession, where we saw a lot of kids in poverty go up, but coverage for kids also went up. So it really is a sort of a success story and a testament to the role that public programs can play. They did exactly as intended, particularly when families were vulnerable. in the most recent recession. Now, if you were to look at this slide and go all the way back to 1997 when ARKids First was created, the rate of uninsured kids in Arkansas was actually higher than the national average. So not only has it dropped below the national average, but it exceeded that national average and started up higher. So Arkansas really is truly a leader among states in terms of driving down the rate of uninsured children. And the video mentioned this, but it's important to say health coverage is really important for kids. Helps them get to the doctor when they need to get there. They get their screenings and early intervention with their regular checkups to make sure we can catch complex issues and developmental delays early and get them the treatment that they need. Helps them not only go to school ready to learn, but attend school so they're not sick and missing school days. There are impacts of health coverage and healthcare well beyond just getting to the doctor. It also impacts education and economic achievement later, which I'll talk about. I should say that this success story that we like to talk about a lot, first of all, not many people know about this. If you ask most public folks, they don't realize that we are at our lowest levels of uninsured kids on record. Most people don't realize the critical role that Medicaid and CHIP play in our country and that we have done such a great job. But also, I think one of the things, and I'm sure we'll talk about it, is some of the federal proposals to restructure Medicaid that came out this week would potentially dramatically reverse these trends in helping uninsured kids. So depending on what happens at the federal level, we could see a lot of these trends reverse and do a U-turn. There we go. So it's important to note that we've also seen coverage for parents improve, particularly with the advent of the Affordable Care Act and Medicaid expansion as Arkansas has adopted through Arkansas Works. Parent coverage is also important for kids. They are healthier parents, have the resources to be the best parents. They can get treatment for things like postpartum and maternal depression, which has a direct impact on kids and their ability to grow up healthy and thrive. Health coverage is also really critical for the peace of mind that, an accident or some medical emergency doesn't bankrupt your family. It is financial security and peace of mind for families. And also it's an important sort of tool for kids and families as well. Okay, how are kids covered? So about a third of kids nationally are on Medicaid and CHIP. But in Arkansas, that rate is much higher. Medicaid and CHIP, which is ARKids First in Arkansas, is the majority of coverage for kids in this state. Half the kids in the state are covered by ARKids First. And so it's a really important coverage source, certainly nationally, but also for kids in Arkansas. If you look at the entire population of Medicaid beneficiaries, nearly half in Arkansas and about half nationally are kids. Again, this is something we don't think about a lot and folks don't know. We think about other populations with Medicaid, but kids are by far the largest group in Medicaid, nationally and in the state. So if you look at the concentration by county here in Arkansas in terms of kids in Medicaid and the Children's Health Insurance Program, even the wealthiest counties have at least a third of kids that rely on Medicaid and CHIP. So you can sort of see the concentration. And then, of course, a number of counties have as much as 77% of kids in the programs. So a really important resource in our state. So, of course, ARKids First and Medicaid and CHIP are important for kids' coverage, also a really critical part of the state budget and helping the state do what it needs to do. So nationally, in terms of all the federal money going to states, more than half of those dollars are Medicaid. This Medicaid alone eclipses combined federal resources states from K-12 education, higher education, prisons, transportation. It is by far the largest single source of federal money coming into states. And in Arkansas, you'll see it's 64% of federal funds coming into this state. And I should say, one of the things about Medicaid that I should mention here is that Medicaid is a federal-state partnership. The federal government pays a portion of all of the folks who are eligible for Medicaid of the cost. In Arkansas, for Medicaid, it's about 70%, if I'm correct. So federal government pays 70% of the cost of everyone in Medicaid. For different populations, sometimes that's higher, as long as they're eligible. And so that is part of why sort of we have this strong federal partner to help pay for the services that Medicaid provides. I mentioned that some of the benefits of Medicaid and CHIP go well beyond just getting health care. And it's been really exciting the last few years. There's been longitudinal research that has looked at kids who got Medicaid through expansions in the 80s and 90s in states like Arkansas, who expanded early and before the Children's Health Insurance Program at the national level. And we're able to look at what was the impact of Medicaid coverage for those kids when they get to be adults. Kids who were able to access Medicaid coverage, more likely to finish high school, more likely to finish college, more likely to have higher wages as adults. They are healthier as adults. And all of this results in a return on investment for those initial savings. And in tax receipts alone as adults, as much as 56 cents on the dollar for initial Medicaid investment for those kids. That doesn't count the return on investment for things like healthier adults or education outcomes. And in fact, the Medicaid, some of these economists that did this modeling showed that the Medicaid access for these kids as adults had better outcomes for kids in education outcomes for kids than things like smaller class size or school-wide education standards. So Medicaid really is a critical investment, not just for healthcare, but for all of the things we know that kids need to be successful in life and to sort of look at economic mobility. So with that, I will turn it back over to Marquita and Chriselle, and we'll look forward to questions later. Am I on?
I think I'm good.
Okay.
First, let me begin, like Elizabeth, and say thank you for the invitation, both Arkansas Advocates and the Clinton School. I am honored to be here, and I'm going to keep my remarks short. I don't have a PowerPoint presentation, but I'm really excited to be here with you and get involved in the discussion after my introductory remarks. As I prepared to think about what I would say to you or what is my theme, the thing that kept coming to me was that the only constant is change, really and truly. And just in talking with people and seeing most of my colleagues and friends that I've worked with over the last 20 years, it's been 20 years, which is hilarious. But I wear many hats, as you kind of heard from my introduction. I mean, my training is in medical care, so I put that hat on sometimes. I put on the public health or the population health hat also, the community advocate hat. I've even had to put on the patient hat and the caregiver hat, and most recently, being a part of the private insurance market or the private sector hat. So it's all of these different hats that really inform and I think illustrate the changes that we are going through here in the state in healthcare and really reflective of what's going on in the nation also. So when I think about the current state of the healthcare system and what's going on here in Arkansas, I'll say as a general statement, we're overall a small state, right? We have growing innovation and unique partnerships, really that are all attempting to address health and healthcare across populations, like the presentation that we saw and the work of Arkansas Advocates and many other people and organizations. But we do that in the context of many challenges, right? The challenges that include increased levels of chronic disease, overall poor health status, and really a challenging and changing fiscal status. But given that, I still think that we are in evolution. We are changing. And here are some of the changes that I kind of want to throw out there, and we can go deeper in question and answer sessions if you'd like. In my new role, I've learned a new terminology and a new language almost. We are moving from a fee-for-service programs or healthcare system to one that values outcomes and populations. And what people mean by that specifically is that historically, and for the most part still now, physicians and the healthcare system gets paid for doing more things for people, to people. essentially. But we want to focus on what are the outcomes that we're getting from that. One of my mentors, Dr. Elders, and I'm sure you all know this statement, she says, you know, we have a sick care system, right? Not a healthcare system. And we get paid for doing things in that sick care system. So we're in a process of trying to change the way we think about that, to change the way we think about taking care of an individual, to taking care of a population of people. Who is that population? That population may be children. That population may be working families. That population may be the disabled, but looking at it more from that global approach rather than one by one. We're moving from treating individual diseases to prevention, right? We talked about. So we're moving upstream, but we're also understanding that what makes you sick or healthy really happens outside the doctor's office, right? We spend most of our time outside of the healthcare system. So we're moving from acute care, what happens to you when you break your arm or you have a car accident, to how do you manage chronic disease? How do you manage chronic disease in the context of an environment that people have different choices? How do we have a healthcare system that is coordinated and organized, as opposed to fragmented and being very difficult to navigate? I've had that experience with my family, and I'm a healthcare provider, and I work in the system. I'm supposed to know this, right? It's still, even for me, it's confusing and disjointed. And then I would also say we are moving from interventions or things that we can do to improve people's health outside the healthcare system. So there are things that we can do to improve inside the healthcare system, right? Make sure people have quality care. But also outside the system, we need to make sure that we have an environment where people can be healthy, have the choices to be healthy. So currently, that's my framework of change. The only constant is change in the healthcare system. Where are we now? Or how are we doing? I think I want to talk about that from multiple perspectives. I'm going to put on my healthcare provider hat first. And I'll say that healthcare providers, and particularly primary care docs, and that's what my training has been in, it's a challenging time. It's a changing time. We're changing how people are trained, which is good. We know we need more primary care docs. We need more docs, period, in some areas in the state. And the framework has to change in that the provider is one person on a team of people taking care of a population of patients, instead of the doctor has to do everything, because nobody can do everything. And then the challenges that healthcare providers are currently having is how do you document that people are getting health care, quality health care that they need, right? And that you are taking care of a population. All that stuff matters. As a public health person, I'm excited to see the changes because I see different people coming to the table across sectors to talk about how we improve health, whether that's health and housing. You have to have a roof over your head. If a doctor's going to write you a prescription and you have to stay on your medications to control your diabetes or your high blood pressure. If you can pay your utility bills or buy your medications. Those types of things matter. And so people are engaging across sectors, the faith-based community, for example. There are many things going on, and that's exciting to me. I think as a community advocate, those people coming together can really make change to improve the health and health care of both low-income children and their families. From a health plan perspective, and that's my newest perspective, I will admit, I'm hearing terms like social determinants of health in meetings, and an understanding of the interconnectivity of all of these things. I'll give you one specific example that I like to use. One is about, say, asthma in children, right? So we know that's a major chronic disease for children, and as health insurers are concerned with people going to the emergency room. So I can identify for you children who bounce in and out of the emergency room with asthma attacks, shortness of breath, that type of thing. Well, what do we do for that person and that family? Is it that we tell them, oh, you need to go to your doctor, make sure you take your medications, have your asthma action plan? Or is it that they should have adequate housing that is not flea or infested that's causing the trigger? How do we make sure that everybody has adequate housing? Maybe that's what we need to do. Or maybe just an air conditioner in the summertime when allergens are out. That would decrease healthcare costs and ER utilization. So you see what I mean about the interconnectivity between other sectors and healthcare utilization? We have to think about it in those different terms. So for me, in order to have a healthy child, which Arkansas Advocates has done a wonderful job and the state has done a wonderful job in doing, that child has to be in a healthy family. That healthy family has to be in a healthy community. How do we support that? And that's going to be the long-term, that's going to have the long-term impact. So where are we now as far as the adult and the family side of things? I think we're still early on. Right now, with the Medicaid expansion and the innovation that we've done here in the state, we're 3 or 4 years in now. Well, we've seen the time trajectory that is taken to make the achievements and prove the achievements for children. And well, I think it's the same trajectory for the larger changes in the state. And I would say it's not a 3-year time frame. It's 10 years, 20 years or longer. That's way beyond anybody's news cycle. That's way beyond anybody's political cycle. So I think we have a unique opportunity here in Arkansas at this time again, like we did in 1997, to really capitalize on the changes that we are all trying to make. So I'll end up with a couple more statements. Like children, health insurance for adults means certain things too. It means access to better care. It means timely preventive services. It means better management of chronic disease, improved health status, and being able to contribute to society, both economically and your family. It means longer life expectancy. But health insurance coverage is just the first step. Just because you have a health insurance card does not mean you have access. We have multiple other issues that we as a state and internally as we grapple with how we cover low income and people who have not had health insurance before. We have issues around health literacy. We have issues around cultural competency and equity and ways that we design our healthcare system. So ultimately, I think we are well on our way, and we are still in this evolving, changing system. This system that I hope at the end of this time will be a safe system, will be an effective system, what we call a patient-centered system. It'll be a timely system. You get care when you need it. Efficient system, because that's important, right? There is a fiscal reality, but also it's an equitable system such that no matter who you are or where you are, you can have access to quality care. So with that, I think I'll stop, and then we can go further, okay?
Thank you both so much. So if we could just delve a little bit deeper, I just have a couple of questions for you all. And you touched on the historical progress we've made, how we've improved coverage for kids, how we've made similar progress for adults. And if I'll just kind of toot our own horns in Arkansas, because we were the first southern state out of the gate to make the decision that it was important to also expand affordable coverage for adults, we are also leading the nation there as well, and only 10% of adults in the state are currently uninsured. But can you all just talk a little bit about that historical progress we've made and kind of what got us there, both from a state perspective as well as nationally? What are some of those key things that have happened that got us where we are today that you haven't already talked about? Because you'll kind of talk about everything. But if we could just highlight kind of what those couple of things are that got us where we are.
Well, I think at the federal level, I mentioned, what was a critical role for Arkansas to be able to make some of these decisions is that there was a federal investment in Medicaid and then subsequently the Children's Health Insurance Program. So Arkansas extended coverage to more low-income kids through Medicaid, but then once the passage of the Children's Health Insurance Program happened in 1997, got additional federal resources to cover those kids. And so from a kid's perspective, I think that was a really critical movement at the federal level. And then also the Affordable Care Act allowed states to not only through Medicaid expansion, but also through marketplaces, have many adults have coverage that couldn't afford it or didn't have it offered to them for the very first time, many of whom are parents and most of whom are working. So I think that, like I said, that's not only important for parents and adults for their health coverage, but also for their kids. And so I think a lot of this story, and which is I think why I'm here, is that there is a strong federal investment and a federal partner with these different laws to make sure states have the tools to do this. And even within that, what we've seen is states have a lot of flexibility right now in Medicaid and the ACA and the Children's Health Insurance Program to design their programs like we've done with Arkansas Works here, to set eligibility levels, to decide things like benefits, premiums and cost sharing, that kind of thing. They have a lot of leeway in how to run their programs, but that there's always that federal investment there to help pay the cost.
I think that the only thing that I would add to that is sort of history is now in terms of what's going on with Arkansas Works. And so just so that I can be clear and level set, Arkansas is very unique with Arkansas Works and how we as a state expanded Medicaid. What we have done is we have taken those Medicaid dollars and applied them to premiums in the exchange. All right, so we have taken a essentially Medicaid population and they are in a commercial health plan. So that is innovative and new, and that gets to the point of compromise of not expanding government but using a market-based strategy to help improve coverage. Now, that comes with difficulty and we're working out, as you all know, the devil is in the details, but that is an innovative strategy that other people are looking at now as a way forward, depending on what happens in other avenues. But so my work has been around how do we implement that and make sure that that meets the needs of our population in Arkansas. And so there are unique opportunities there, but again, I would say history is now in the making.
Dr. Nash, that's a great segue into my next question. If you all have anything to add in addition to your comments about Arkansas Works and how we're using the private sector, if you all have any additional comments kind of on that interplay between public and private coverage and how that is also influencing and shaping our current but also the future healthcare system.
So I think that we often think about public and private coverage, not so much here because of the innovation with Arkansas Works, but as two separate things. And increasingly nationally and even here, the lines are very much blurred. The majority of kids and a lot of adults nationally are in managed care, in Medicaid, are in managed care plans. So Medicaid is paying private plans to run their Medicaid programs in most states. I know there's a managed care conversation happening here as well. But even without that, there are a lot, the private option or the Arkansas Works here has Medicaid expansion beneficiaries in the marketplace, and that's sort of a public-private partnership. So it's not, I think that there are a lot of sort of public-private blurred lines, so to speak, happening. And so I think part of the opportunity is to think about how to do things for everyone so that everyone has the same sort of healthcare standard across public and private funding sources. But also, I think one of the challenges is really making sure across, no matter who's paying the bill and where we have it, is we have good data and information to know how folks are faring no matter where they're getting their coverage. And I think that remains a challenge and tries to get at some of the things that Chriselle was talking about and really understanding what the value of that health coverage might be.
So I have to ask, I think you guys are prepared for this one. Commenting on what's happening nationally with healthcare. So this week, as we probably all know, if we've been watching the news or turning on a radio or even talk to your neighbors, that legislation was introduced, our bill was introduced at the federal level to repeal Obamacare or the Affordable Care Act. And one of the surprising things about that legislation was that it goes even further than just repealing the Affordable Care Act, but also makes some recommendations on restructuring how we fund the Medicaid program. So if you all can comment on that and just generally on kind of the future of the healthcare system. Obviously, we don't know what's coming next, but would love to hear you all's comments and feedback on that.
I have a lot to say on this, yes. So I think Marquita alluded to it, but I wanted to say, a lot of the conversation around the Affordable Care Act repeal and replace has been around the marketplaces and what happens with tax credits, as well as what happens with Medicaid expansion. And those are really critical pieces. And in fact, I think the proposal would essentially phase out Medicaid expansion as we know it in terms of federal support to states. But I think what we've found is that we're really bearing the lead in what's going on in these replacement plans, and that not only would it affect the Affordable Care Act repeal, it would also radically restructure Medicaid financing as we know it. So as I mentioned, right now, Medicaid for all populations it serves, and for 50 years for kids and seniors and people with disabilities and low-income parents, has guaranteed that the government's going to come in with its federal match, in this case 70% or more, for benefits for folks who are eligible in the state. This is an open-ended guarantee, and that no matter what happens when enrollment changes, when health costs surge, that federal match is going to be there. This proposal would in effect cap the federal contributions to states and shift costs to states. Essentially, states would be left with less federal money and have to make decisions about ultimately who and where to cut. I mentioned states have a lot of discretion over eligibility, over benefits, over whether folks pay for premiums or cost sharing, especially low-income folks. It would, and I think one estimate we've seen is that over the next 10 years, the proposal to restructure Medicaid financing would shift more than $370 billion to states in the next 10 years. States would have to pick that up, and they would have to make the hard decisions about, do we need to cut benefits for these folks? Do we need to, or do we let the state pick up the cost that the federal government's now not doing, and then cut other services that the state funds for kids and families? So I don't think that it's an understatement to say this would radically change how Medicaid works and has worked for states for the last 50 plus years. And it's particularly important because, the federal match has been there when epidemics like HIV in the 80s came up, and states were able to help pay for treatment for that. The opioid crisis right now means higher health costs in some states and need treatment. When prices go up, like for EpiPens for kids, if this federal funding is capped and those health costs go up in that way, the states wouldn't have a strong federal partner to help share in those costs. And so to us, this is really one of the most critical pieces of what could happen and could absolutely reverse all the success we've seen, not only in covering kids and families, but everyone who relies on Medicaid, including seniors and folks with disabilities.
I think just to add to that, it goes back to my theme of the only constant is change. I have more questions than I have answers. I think about, it seems to change from minute to minute, depending on, what's in the news cycle. Is it Obamacare light? Is it 0.5? I don't know. In the health policy arena, we're trying to figure out, what does this mean? What does this mean for a state like Arkansas that already chose to expand Medicaid and do it in a different way? I don't know what the answer will be. I think we're still early in this process, but I think that the forces that produced where we are still here. Unsustainable costs, lack of access, lack of quality, and what I personally don't want to see happen is that we balance the cost of that on the backs of those who can least bear it or afford it, because at the end of the day, we're all still going to pay, right? We're going to pay in economic costs, we're going to pay in human costs, and we're going to pay in lost potential of children and families. So I I don't know what the answer is, but I think that because of the innovations and because we can pull people together in a room like this in Arkansas across different organizations and sectors and have a success like ARKids, we can do the same thing in whatever context that comes down. So I'm trying to be optimistic is my point. It's never a dull day. Okay.
Thank you. That was a perfect closing comment, actually. ARKids, let's keep thinking along that line of thinking. Investment pays off. I think we have time for a few audience questions.
Do either of you think that the United States will ever develop the political will to have Medicare for all? Single payer.
I am not a politics expert. I will say, when the Affordable Care Act was being debated in a very different political environment, that was a proposal on the table, and it did not get very far.
Yeah,
So that's you know.
And then the fallback position, if you remember, was the public option, right? I still don't see that political will. I still think that we have a sense of rugged individualism here as opposed to collective good. And I agree. I think that, for example, I look at it this way. Life is a journey, a trajectory, right? And necessarily, we're all going to need health care at some point in time. That's just kind of life. And I would want to have, just in case I need it, when I need it, it's there, and it's quality, and it's good. And I want that for everyone. I don't think that we have that sentiment. I still think that we, as a culture, operate in a zero-sum game. That means if you have any, that means I have less. That's a problem. So until we get to the value point of this is a common good that we all want in the United States of America, that's going to be a tough thing to get done. But I hope so.
Thanks. A quick question for you. When our state's Medicaid expansion for low-income adults was passed a few years back, one of the kind of big side benefits during the first couple months was that there was quite frankly, almost a surge in kids who got signed up for ARKids. You want to talk a little bit about that and why why the expansion is important for kids?
Yes, I cannot believe that I didn't say this earlier. I mean, I mentioned parent coverage is important for parents to be great parents and for kids' health. As more parents get health coverage, oftentimes they get their kids in the door as well. Oftentimes they don't know their kids might be eligible for coverage and they're already eligible for Medicaid or CHIP or ARKids here, or for whatever reason, they didn't realize it. So when a lot of parents got coverage for the first time for the Affordable Care Act or Medicaid, a lot of kids who were already eligible for the program got in as well. And so again, even if we just lost the Medicaid expansion nationally or here in Arkansas, you potentially see those trends in uninsured kids reverse as well as kids drop off the program and don't, there's a lot of confusion about who's eligible for what. So that's a really good point, Rich.
And so I'll just add, in Arkansas alone, in that first year of enrolling those adults in the plan, we saw 30,000 more kids who gained access to coverage. It's called the welcome mat effect, and just hugely important in terms of keeping kids covered. And at a minimum, we know that those 30,000 kids in Arkansas probably would still be without coverage if not for their parents gaining coverage as well. No one else has questions? Okay.
I did not live here during the time when ARKids First was created. So for my benefit, if for no one else's, could you give me a very quick thumbnail description of how CHIP/ARKids differs from regular Medicaid?
Sure. I mean, so the biggest difference that you heard there in the video, it's actually the income level. And so you have so when we first started ARKids First, the program that's discussed in the video, that was only considered the expansion. And so it went up to higher income levels. And I won't confuse you by starting talking about federal poverty levels and FPLs and stuff, but just know that it covered families who certainly were still struggling financially in many cases, but really a lot of the working parents. And so even though they were working, still unable to afford coverage and didn't have affordable coverage options for their kids. And so later we rebranded basically the entire program in the state of Arkansas. And so now when we talk about ARKids First, we're talking about all the kids who were getting traditional Medicaid coverage, as well as a slightly higher income who were covered through the CHIP dollars. And so we refer to it as ARKids A. You might hear an ARKids B, but just at a basic level, it's the difference in terms of the eligibility. There are some differences in the benefits package as well, but